The management of type 2 diabetes follows a patient-centered, stepwise approach, beginning with foundational lifestyle modifications, including diet and exercise. When glycemic targets, typically measured by HbA1c, are not achieved with lifestyle alone, pharmacotherapy is initiated. There are numerous non-insulin medication options available today. The established first-line therapy, after lifestyle intervention, is metformin. Metformin belongs to the Biguanide class of medications. Its primary mechanism of action is to decrease hepatic glucose production, a process known as gluconeogenesis. It also increases peripheral glucose uptake and utilization. Key advantages of metformin include proven efficacy, a weight-neutral profile, or even modest weight loss, a very low risk of causing hypoglycemia, low cost, and some evidence for potential cardiovascular benefits. Common side effects are gastrointestinal disturbances like diarrhea, nausea, and abdominal discomfort, which are often transient and can be managed by starting at a low dose and taking the medication with food. A serious but rare risk is lactic acidosis, which is increased in patients with renal impairment, liver disease, heart failure, or hypoxic conditions. Dosing typically starts low, at 500 milligrams once or twice daily with meals, and is gradually titrated upward. An extended-release formulation is available and may improve gastrointestinal tolerance. Metformin is contraindicated in patients with severe renal impairment, specifically an estimated glomerular filtration rate less than 30 milliliters per minute per 1.73 square meters, as well as in metabolic acidosis and severe liver disease. When metformin alone is insufficient or cannot be used, a second agent is added. The choice among major drug classes is highly individualized. Sodium glucose cotransporter 2 inhibitors, abbreviated as SGLT2 inhibitors, include drugs like canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. They work by inhibiting the SGLT2 protein in the proximal renal tubules, which blocks the reabsorption of glucose back into the bloodstream and promotes its excretion in the urine, a condition called glucosuria. Key benefits of this class include moderate glucose lowering, promotion of weight loss averaging 2 to 3 kilograms, a modest reduction in blood pressure, and most importantly, proven cardiovascular and renal protection in patients with established cardiovascular disease, heart failure, or chronic kidney disease. Common side effects include an increased risk of genitourinary infections such as yeast infections and urinary tract infections, and volume depletion leading to dehydration or hypotension. There is a rare but serious risk of euglycemic diabetic ketoacidosis, where patients can develop ketoacidosis with normal or only mildly elevated blood glucose levels. Other risks include a potential increased risk of lower limb amputations, notably with canagliflozin, and Fournier's gangrene, a rare necrotizing fasciitis of the perineum. Initiation of these drugs requires adequate renal function, with specific thresholds varying by agent but generally above an estimated glomerular filtration rate of 20 to 45. Glucagon-like peptide-1 receptor agonists are injectable medications that include liraglutide, dulaglutide, semaglutide, and exenatide. They mimic the body's natural incretin hormone, GLP-1. Their mechanisms are multifaceted. They increase glucose-dependent insulin secretion from the pancreas, suppress glucagon secretion, slow gastric emptying, and promote satiety in the brain. Key benefits are potent glucose lowering, significant weight loss ranging from 3 to over 8 kilograms, a very low risk of hypoglycemia, and proven cardiovascular benefit in reducing major adverse cardiovascular events in patients with or at high risk for cardiovascular disease. The predominant side effects are gastrointestinal, including nausea, vomiting, and diarrhea, which are usually transient. There is a potential risk of pancreatitis, requiring monitoring for severe, persistent abdominal pain. Due to a rodent tumor risk of uncertain human relevance, they are contraindicated in patients with a personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia syndrome type 2. Administration is via subcutaneous injection, ranging from daily to weekly, though an oral formulation of semaglutide is now available. Dipeptidyl peptidase 4 inhibitors, or DPP-4 inhibitors, are oral drugs including sitagliptin, saxagliptin, linagliptin, and allogliptin. They work by inhibiting the DPP-4 enzyme, which breaks down the body's own incretin hormones, thereby increasing endogenous levels of glucagon-like peptide, 1, and glucose-dependent insulinotropic polypeptide. Their key benefits are moderate glucose lowering, a weight-neutral effect, a low risk of hypoglycemia, and generally good tolerability as an oral pill. Side effects are generally mild and can include nasopharyngitis and headache. There is a rare risk of acute pancreatitis and severe joint pain. Importantly, cardiovascular outcome trials for this class have shown neutrality. They do not provide the additional cardiorenal protection seen with SGLT2 inhibitors or GLP-1 receptor agonists, making them a less preferred choice for patients with established heart or kidney disease. Sulfonylureas, specifically the second-generation drugs like glimepiride, glipizide, and gliclazide, are older oral agents. They stimulate insulin secretion from pancreatic beta cells by closing ATP-sensitive potassium channels. Their main benefits are potent glucose lowering and low cost. However, they have significant drawbacks. A high risk of hypoglycemia, particularly in the elderly or those with renal impairment. They cause weight gain, and there is concern they may contribute to beta cell exhaustion over time. While less favored in modern guidelines due to this safety profile, they remain a viable option when cost is a major barrier. A clinical pearl is to use short-acting agents like glipizide in the elderly or those with renal impairment to minimize prolonged hypoglycemia risk. Thiazolidinediones with pioglitazone as the primary agent used today work by activating a nuclear receptor called peroxisome proliferator activated receptor gamma. This increases insulin sensitivity in muscle and fat and decreases hepatic glucose output. Benefits include durable glucose lowering and a low risk of hypoglycemia when used as monotherapy. Their significant side effect profile limits use. They cause weight gain and fluid retention, which can exacerbate or even precipitate heart failure. They are contraindicated in New York Heart Association Class 3 or 4 heart failure. They also increase the risk of bone fractures, especially in women, and there is a potential increased risk of bladder cancer with long-term, high-dose pioglitazone use. Consequently, their role is generally as a third-line agent, used cautiously in selected patients without heart failure or high fracture risk. Other oral agents include meglitinides, like repaglinide and natiglinide, which are short-acting insulin secretagogues taken with meals to control postprandial glucose. They share the hypoglycemia and weight gain risks of sulfonylureas. Alpha-glucosidase inhibitors, like acarbose and miglitol, delay carbohydrate absorption in the intestine, but have a modest effect and frequently cause gastrointestinal side effects like flatulence and diarrhea, leading to rare use in practice. Fixed-dose combination tablets, which combine two agents like metformin plus an SGLT2 inhibitor in a single pill, offer advantages in improving adherence and simplifying the medication regimen, though they offer less flexibility for individual dose titration. The 2024 American Diabetes Association and European Association for the Study of Diabetes consensus highlights a modern treatment algorithm. Step 1 remains lifestyle plus metformin, if not contraindicated. Step 2, selecting an add-on therapy, strongly prioritizes agents with proven cardiorenal benefit if the patient has or is at high risk for specific conditions. For patients with atherosclerotic cardiovascular disease, a GLP-1 receptor agonist with proven benefit, such as liraglutide, semaglutide, or dulaglutide, is recommended. For patients with heart failure, especially with reduced ejection fraction or chronic kidney disease, an SGLT2 inhibitor with proven benefit, like empagliflozin, canagliflozin, or dapagliflozin, is preferred. Step 3 involves considering triple therapy with complementary mechanisms if further glycemic control is needed. Step 4 is the introduction of insulin therapy, typically starting with basal insulin, if targets are not met with oral and injectable agents. Special populations require tailored choices. In chronic kidney disease, Preferred agents are SGLT2 inhibitors if the estimated glomerular filtration rate is adequate, GLP-1 receptor agonists, or the DPP-4 inhibitor linagliptin, which is not renally excreted. Many other drugs require dose adjustment or avoidance. For the elderly or frail, avoiding hypoglycemia is paramount, making metformin, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists preferred, while sulfonylureas require extreme caution. For patients with obesity or high weight loss goals, GLP-1 receptor agonists and SGLT2 inhibitors are optimal. When cost and access are primary concerns, sulfonylureas, metformin, and glitazone are often the most affordable. Monitoring and patient counseling are critical. Monitoring includes checking HbA1c every 3 to 6 months, periodic assessment of renal function, especially for patients on metformin or SGLT2 inhibitors, and tracking weight and blood pressure. Key counseling points include, for patients on SGLT2 inhibitors, emphasizing the importance of good hydration, genital hygiene, and recognizing symptoms of ketoacidosis like nausea, vomiting, and abdominal pain. For those on GLP-1 receptor agonists, teaching proper injection technique, strategies to manage initial gastrointestinal side effects, and symptoms of pancreatitis. For patients on sulfonylureas or meglitinides, ensuring they understand how to recognize and treat hypoglycemia. And for those on metformin, advising to take it with food and to report severe gastrointestinal issues or symptoms that could indicate lactic acidosis. In summary, non-insulin pharmacotherapy for type 2 diabetes is highly personalized. The modern treatment paradigm strongly favors the early use of agents with proven cardiovascular and renal outcome benefits, specifically SGLT2 inhibitors and GLP-1 receptor agonists, in appropriate patients, moving decisively beyond a strategy focused solely on glucose lowering. Ongoing research continues to refine therapeutic sequences and develop novel agents, such as dual GIP and GLP-1 receptor agonists, like tirzepatide, promising even more tailored and effective management in the future. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.